Hello, good evening. Are you able to see the screen?
Yes, sir.
Yeah, okay. So let's continue the recent concepts in headache. So we'll have mostly the stress will be on tax and few headaches, that is other primary headaches. And I'll have an introduction on migraine. So after introductory sensitization, there will be 14 cases of headache in various settings. There will be migraine and trigeminal autonomic cephalgias, post-traumatic headache, other primary headaches and interventions in headaches, mostly the neurostimulators and also peripheral nerve blocks. These are the important things which we need to learn. So we'll be dealing with them. So the classification, is the screen visible? Hello.
Sir. Yes, sir.
Yeah. Okay. So the primary headaches, migraine, tension type headache, trigeminal autonomic cephalias. These are episodic or chronic, and we keep getting these cases: cluster headache, paroxysmal hemicrania, sona, hemicrania continua, maybe remitting and unremitting also. And we'll be on the other primary headaches. We'll be talking a bit about cough headache, exercise headache, and maybe sucks headache, and primary thunderclap headache, and new daily persistent headache, NDPH. These are the important items which we will be discussing as cases also. So the international classification of headache disorders is very well known to us, and the occipital neuralgias, trigeminal neuralgias also confused with the primary headaches. We will be briefly touching on trigeminal neuralgia in this discussion. If you look at the migraine with ARA, which affects about 25 to 30% of people, 35% of the people, we have the headaches. It can be brain a typical ARA. So hemiplegic migraine, and we can very rarely we can encounter that. The episodic migraine is less than 15 days a month, and more than 15 days a month for more than 3 months constitutes a chronic headache, as per the criteria by International Headache Society criteria, which we usually follow. Right. So migraine versus tension type headache, we often get confused. So two pain characteristics of migraine are one-sided, moderate to severe, throbbing, worse with activity. So historically, we should be able to elicit these points. This is light and sound sensitivity, nausea or vomiting. Duration can be 4 to 72 hours, 5 or more episodes, not from secondary cause, maybe with or without ARA. This is third edition of ICHD. The tension type headache, on the other hand, has got two pain characteristics. It's bilateral, mild to moderate, pressure like, not worse with activity. light or sound sensitivity will be there or may not be there. Duration is not 72 hours, up to 7 days. 10 or more episodes a month and 30 minutes to 7 days, not from any secondary cause. What is migraine? It's a neurological disorder characterized by recurrent headaches. Pain is influenced by biological, social, and psychological factors, which we'll see. In altered sensory processing, central sensitization takes place, and there will be some focal neurological deficits that especially RS, and it can extend up to motor deficits also. The burden of disease in WHO Global Burden of Neurological Diseases study, migraine is the leading cause of disability from age 10 to 60 among all the neurological diseases. Disability measured in disability adjusted years. There are references mentioned here. Genetics, the risk factor heritability estimated at about 30 to 70%. 171 susceptibility genes and counting. The functions of the genetic susceptibility include neuronal function, vascular function, and nitrous oxide oxidative stress pathways, glutamatergic transmission, ion channels, of course, homeostasis. And about environment, I'll touch briefly upon. There are limited information about environment. And in a Finnish Jiva study, polygenic risk factors computed for about 4,930 people with migraine who had age of onset data. Those with migraine onset less than 20 years of age had higher polygenic risk factors than those with onset more than 20 years of age. The odds ratio is slightly 1.11, and the CI is about 1.05 to 1.18. So it looks significant. Let us define migraine and criteria and description. At least 5 attacks that should meet the criteria which are mentioned in B, C, and D. That is headache duration of 2 to 72 hours. Earlier it used to be 4 hours. Now it's been brought down to 2 hours. At least 2 of the following are present. Location unilateral or bilateral or frontotemporal. Pulsating quality, moderate to severe intensity as on VAS scale, visual analog scale, aggravated by physical activity. And the D is at least one of the following is present. Nausea, vomiting, photophobia, phonophobia. So when we take history, we have to take history to decide this. And E is not attributed to another disorder. Look at the pathophysiology. The signals from the trigeminal nucleus complex activate meningeal dural blood vessels, creating a dural neurogenic inflammation and a protein extravasation. This stimulates a feedback loop back to trigeminal nucleus, activating a second order neurons, the ganglia. The peripheral neuron sensory outputs from V1, that is ophthalmic and mandibular maxillary, via the trigeminal ganglion, as well as the cervical afferents from the upper cervical dorsal root ganglion, converge on the trigeminal cervical complex. They also come into play. From here, the neurons ascend and synapse multiple thalamic nuclei, as well as the branching off to project to brainstem striations that include the locus coeruleus and rostral ventromedial medulla and periaqueductal gray matter and hypothalamus. So from thalamus, the sensory information is projected to multiple cortical areas. So usually migraine is a systemic disease. That's why you've got so many deficits can happen. There is a trigeminal autonomic reflex between sensory afferents and the somatosensory nucleus via the sphenopalatine ganglion that explains the autonomic symptoms of the migraine. So there may be interventions which can target these pathways. If you look at the pain phase, ascending pathway, two major things happen during pain phase of the migraine. The trigeminal nerve endings in the meninges, large dural blood vessels release vasoactive neuropeptides. These are CGRP, substance P, and PSCAP that cause vasodilatation and neurogenic inflammation. These are exactly the targets for new drugs development, which we'll talk. The trigeminal nerves transmit pain signals to spinal trigeminal nucleus. Then second order neurons transmit signals to thalamus, that is ventral posteromedial nucleus, which collaterals to other areas, hypothalamus, periatrial gray matter, and superior salivary nucleus. Next, the third order neurons in the thalamus, they project to the multiple cortical areas, not just primary sensory cortex, the sensory cortex. It all goes to visual cortex, motor cortex. So you can see the complexity of the network involved explains the multimodal symptoms. The descending pathways also are important. The descending pathways that modulate spinal trigeminal nucleus. They are generally involved in endogenous pain modulation, and generally the data suggests that there is a decrease in activity in people with and without migraine. The descending projections from somatosensory and insular cortex initially target thalamus and hypothalamus. From there, the direct and indirect descending project target areas with high concentrations of endogenous opioid receptors like periatrial gray matter and rostral ventromedial medulla. These can constitute treatment targets too. So you got a pain phase, ascending pathways and descending pathways. And these are the, you can do erenumab, also all these atogepant, and all the Gpants, rimegepant, ubrogepant, these are all available in the Indian market, but they're very costly. And you can have monoclonal antibodies, Gpants, this blockade of CGRP receptors. CGRP receptors are here, and you can see them, CGRP receptors. Yeah. And then 5-HT1B, 1B receptors, 5-1-HD1F receptor, and CGRP. So these are the monoclonal antibodies and the triptans and ditans, lasmiditan. So slowly, all these are available in Indian market in some extent, and even the monoclonal antibodies, eptinezumab and fremanezumab, galcanezumab, but they're very costly, about 20,000, 30,000. So basically, all these trigeminal nerve fibers, these released when the synaptic release occurs, all these amines, they cause vasoconstriction initially, then vasodilatation in the middle meningeal artery and various other arteries in the brain. If you look at the neuroimaging studies are many, but they are very non-specific. If you look at the white matter abnormalities, the mixed findings, whether small white matter lesions are more common in youth with migraine is a study. It's a case control study of 248 youths versus 490 controls. All the young chaps have headaches. About 54% had small white matter lesions, and there is no difference between headache versus controls. This is one of the largest studies to date. So non-specific white matter abnormalities are common, and there is a meta-analysis also about the neuroimaging saying, and the overall there is no significance. You can see all the studies, the migraine and controls, you can see the diamond is crossing the line of no effect, and the odds ratio is crossing 1. So there is no significant of these white matter hyperintensities. And neuroimaging gray matter, if you look at, there is a case control study of 120 young females with migraine versus 60 female controls aged 7 to 27 years. They used high resolution structural MRI. They used, hello? Did you? Okay. 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 So this neuroimaging gray matter, this used a high resolution structural MRI to quantify the hippocampal volumes and shape. Is there any decrease in the volume? The migraine group had decrease in hippocampal volumes and different shapes versus when compared to controls, 120 migraine patients and 60 controls. Children and adolescents had decreased volumes than controls. Adults had increased volumes than controls. So these are non-specific findings. They're nothing which is very significant to talk about. So the another study was there. 28 youth with migraine, 28 matched controls were studied. MRI was used to quantify the cortical thickness and the gray matter volume. Early puberty females had increase in gray matter in anterior mid-cingulate cingulate cortex, primary motor cortex, putamen, thalamus, and hippocampus. And early puberty males had decreased this gray matter in these areas, and especially in the anterior mid-cingulate cortex and medial frontal cortex. So still, we are learning about all these findings and their significance. Nothing is very sacrosanct, and we can't generalize anything to anything, any particular abnormality. Case control study of 36 young people with migraine and matched controls. They use a resting state functional MRI to look at the functional connectivity patterns. Adolescents had increased connectivity in default mode networks, cerebral and visual networks versus controls, and versus adults also with migraine. So there are network disturbances which can account for the many of these manifestations. Okay, so people have done MRS also on thalamus and cingulate gyrus and occipital cortex. And when the 29 patients who had 4 to 20 days a month of headache and at least 2 weeks, 4 MRIs and daily diaries were maintained. Youth with migraine likely showed differences in white matter, gray matter, functional connectivity, and neurochemistry versus controls. There are likely developmental differences. These need replication and more studies. So neuroimaging, actually MRS data has shown that 2 adult studies were changes in occipital cortex, glutamate interictal versus headache phase. You can see signal changes for choline, creatine, NAA, and myoinositol. So this is the thalamus region, and this is thalamus glutamate, and this is GABA. And you can see 24 hours headache phase onset, 24 hours. And what happens is most of these amines are either falling or increasing or decreasing. So studies are ongoing. So far, there is no conclusion about these observations. So let's look at the biopsychosocial factors. Meta-analysis has shown anxiety symptoms and disorders, depressive symptoms and disorders. And these are the exposures in the meta-analysis. Outcome is migraine. And they studied especially children and adolescents. These are the chaps who studied. So what does it say? How many patients were there? The searchers, there are about 4,946 abstracts have been screened for this meta-analysis. They searched all the bases, the databases, and they could recover about 405 full texts. They were screened. Only 80 included because the others were excluded from because of duplicacy, study design faults, not migraine, not pediatrics, and other reasons. So a lot of them were excluded. Only for 80 were included, which was the result you have seen in the previous slide. So the depressive symptoms in migraine are more than controls, and it has got a moderate effect size. There is twice the odds are twice of depressive disorders in migraine versus controls. So the odds ratio is 2. It's very really significant. Anxiety symptoms are more when compared to controls. This all effect size also a large effect size, 1.13. And odds of anxiety disorders, migraine versus controls, also you can see the odds ratio 1.93, which is very significant. So most of the migraine sufferers have depression and anxiety. The social factors, the family factors, you can see when the child develops, it's very important phase, and it has got a large effect, the impact on the headache. It may be because of developmental chronic pain, decrease of friendships, the impact of parental and siblings, occupational planning. They all affect, but why? What happens? Why these social factors come into play? And what the parents' role in this? So there are 2 studies. Toxic stress, it is called. 2 longitudinal cohort studies. They are about 2,000 adolescents, 1 cross-sectional population-based study using the same these chaps. What happens in this study is the outcome is incident migraine at 14 to 15 years. And the exposures around very young age, about 1 year, 2 to 3 years, 4 to 5 years, hostile, ineffective parenting, putative, aversive parenting, family depression, and all these things may play a role. And the internalization of symptoms at 8 to 9 years happens, and then start having migraine, childhood migraine. So social factors, internalizing psychopathologies, so low family functioning, parental depression, and so all these factors are to be taken care of during first 5 years of life. And then they start, if you don't take care, then they start affecting around 8 to 9 years, and children develop by 14, 15 years migraine. So the social factors, the meal regularity should be one of the factors. The screen time plays a big role, and household smoking also affects. Late chronotype, and that's the something like all the, you can say, the stimulants that will happen in the adolescent age will have an effect. So now you see these chronotypes like ethyl alcohol, cigarettes, smoking cannabis, vaping, and all these things, all substance exposures at dose response relationship with frequent recurrent headaches. There are very hardships in headache management, anxiety, depression, OCD, stress, sleep deficits, difficult to identify headache triggers, consistent tracking of symptoms, caregiver availability or schedule, and awareness of headache or observation, existing medications, polypharmacy, communication challenges. See, headache for neurologists very common, and we should be able uh, to manage them effectively, diagnose them correctly. And there are a lot of studies which have happened, which have brought into market many drugs. And so there are some acute therapies. And triptans, they are also level A recommendations, and antiemetics, and that is especially domperidone and metoclopramide ought to be given, though there is a likelihood that extrapyramidal symptoms may come. The ergots are also used earlier. They also have level A and B, and GPANs, ibrugepant and rimegepant and javegepant. So these are now established efficacy, moderate to high efficacy. They are not contraindication patients with any of the vascular conditions. So, and ditans, lasmiditan, and established efficacy, but tolerance is a problem here. There are no contraindications. Level C is opioids. And see, these are the anti-CGRP antibody, that is eptinezumab, fremanezumab, and galcanezumab, and anti-PSCA P38 antibody, and anti-PSC receptor antibodies. And what we concentrate is only on CGRP antibodies and CGRP receptor antagonists, that is GPANTs, and which act on the calcitonin gene-related peptides. So if you look at these, the product ibrugepant is available, rimegepant available in India, but they are very costly. The dose is 50 milligrams or 100 milligrams repeat dose, daily once a day. And one thing which you should know is that one drug is used for prevention solely, that is atogepant, and rimegepant can be but both acute and preventive. So these are all have been approved in 20 and 21, 23 for by FDA for daily use, and per oral route and intranasal also javegepant is available. So once daily doses, and you can check the doses when you want to start the treatment. Check the cost first. The cost is very high, and if a month the cost may go up to 10,000 to 15,000. Very, and the whatever drug you choose, please check the cost first. So approach to migraine preventive therapies and comorbidities and preference. Body weight, if it is there, you use topiramate versus tricyclic antidepressants. Insomnia, you can consider TCA. Depression, you can consider TCA and venlafaxine. Baseline blood pressure and heart rate also, you see whether we can use propranolol or not. Exercise intolerance. POTS could benefit from low dose beta blockers, that is postural orthostatic tachycardia. Vascular risk factors, they are there, then you can use Botox or CGRP monoclonal antibodies, self-injection monthly. So previous treatment trials, and you can go into all these details when you uh, think of preventive therapy, and I'll give you some indications later in the course of the talk. And insurance requirement for our patients here, Botox is if they are insurance supported, then we are able to give, otherwise costly treatment. So now approved for both episodic and chronic migraine. The treatments or episodic migraine, the atogepant dose you can see that has been approved by government for usage. Chronic migraine 60 milligrams. Strong and moderate inducers, if you are there, you are using rifampicin, cyclosporin, you have to modify the dose. Hepatic impairment, avoid use, and fetal harm, they're not to be used in pregnant ladies, and inadequate evidence in the lactating mothers also. End stage renal disease, liver disease, and the enzyme inducers. So you have to modify the dose when you start using. And for chronic migraine, it is 60 milligrams daily. That is the atogepant. So then the monoclonal antibodies, that is Aronumab, and this drug was available in India, but slowly the chap stopped supplying. There's an antibody against the CGRP receptor, 70 milligrams or 140 milligrams monthly injection. And you can see these are very, the injections are monthly or quarterly, then very convenient to take, but each injection is very costly. Galantamab maybe about 30,000-40,000, antibody against CGRP ligand. So, but you check the date, they are available. They are available in India. I checked in the market, they're available, but we are not yet using, only learn about them. But I think now in future, we will go away from all the topiramate, valproates into this group of monoclonal antibodies and GPANTs. So one has to really learn about these drugs and start using them. So efficacy, migraine prevention, and let me go. Right. So the efficacy has been established, as I said, in 43 to 62%, 50% responder rate in episodic migraine, and chronic migraine also, same up to 61%. The efficacy head-to-head comparison with topiramate was studied, and there also the primary endpoint is medication discontinuation due to adverse effects, and most patients of topiramate have discontinued as compared to Aronumab. So this targeted therapy, our current treatment approach is American Headache Society consensus statement on these antibodies. Inability to tolerate due to side effects or inadequate response to a 6-week trial of at least 2 of the following, then you can consider that. That is topiramate, divalproic sodium valproate beta blocker, metoprolol, propranolol, timolol, tricyclic antidepressants, amitriptyline, nortriptyline, serotonin, norepinephrine reuptake inhibitors, venlafaxine, duloxetine, and established efficacy or probable effect according to the AAN IHS guidelines. So these are the drugs which are to be first used, and you have to see about 6 weeks trial. Comorbidities, and because these drugs cause constipation, you may not like to use. Pregnancy, you don't use. Hypertension, you may not use. Can be used in conjunction with Botox, meaningful improvement, but insurance limitation. So CGRP monoclonal antibodies and GPANTs, effective and tolerable, mindful of adverse effects. So these are the guidelines of AHSD, that is American Headache Society Consensus Statement Guidelines. There are some neuromodulation devices, and I have seen a couple of them when I was in American Academy of Neurology annual conference. But these devices are used for acute treatment and also some prevention treatment. But when you use them and stimulate them, there will be a local pain. That pain is unbearable for many people. So the device therapy, though approved since 2014, and but not very favored because it causes some discomfort. So all the preventive therapies, anti-epileptics, topiramate, divalproex sodium, and these are level A evidences. And propranolol also level A, metoprolol level A, and Botox is level A, and these are the MAPs are all level A, and PANTs are established efficacy. So, but whenever you have to choose, you have to think of what is the patient profile and which one you want to use. So let's look at the case one. A 39-year-old female presents with recurrent headache since the onset of menarche. These are bilateral, throbbing, 8 to 10 on visual analog scale, associated with phonophobia, photophobia, nausea, but there is no aura. Frequency is once a week plus at times of periods. Duration 8 hours outside of the period and 4 days during the period. She has significant disability, missing work and other activities. Why I choose this case is most of us, we never ask whether she's having problems during menstruation or not. So in this context, which are the following changes during the menstrual cycle most influence menstrual migraine? Increasing estrogen levels, declining estrogen levels, inhibition of prostaglandin levels, increasing progesterone levels, declining progesterone levels. What is that will so you can unmute all of you, and I'll unmute you. You can answer this question. Yes, correct. No.
D, sir. Progesterone levels increasing.
Progesterone. I'm afraid that is not a correct answer. You are saying D. You're saying D, no? Hari? It is declining estrogen levels. Okay. So answer is declining. I am all unmute. You can unmute and answer the questions. You see that there is no noise. So this is a menstrual migraine. It affects about 20 to 70% of women, depending on the population which you are serving. Tends to be stronger, lasts longer, is more associated with nausea, has greater disability than non-menstrual migraine. So the pure menstrual migraine exclusively occurring around the menses, starts between 2 days prior to menses onset to 3 days into menstruation, has been experienced in at least 2 or 3 menstrual cycles. Menstrually related migraine, like pure menstrual migraine, but migraines also occur at other days of the month. Key triggers are estrogen withdrawal just prior to menses, and of course, prostaglandin release. The pituitary role of estrogen as a neurotransmitter modulator, it modulates a serotonergic tone, enhances glutamate, and inhibits GABAergic activity, possibly explaining the increase of migraine aura in high estrogen states. We also have a regulatory effect on the trigeminal nerve, which modulates CGRP. Low estrogen is associated with reduced ability to activate opioid system. So this lady is missing 2 days of her period and is less productive or absent from work on other migraine days. Topiramate and amitriptyline were ineffective. Acutely, she is using sumatriptan 100 milligrams, which helps outside her period, but not during her period. So the story continues, and which of the following is the next appropriate step? Add tab-verapamil for prevention and continuous sumatriptan. Add a CGRP monoclonal antibody for prevention and change the triptan to frovatriptan, which is also available in Indian market.
proceed with Botox for prevention and continuous sumatriptan. She does not need any preventive medication. So which one you would like to do in this case? Any replies? Want to go back to the question? Topiramate and amitriptyline were ineffective. For acute, she was taking sumatriptan 100 milligrams, which helps only during her periods. So what will you do now? Any answers? Any answer for this? You can unmute yourself and answer. Okay. Pranav, can you answer? Srihari, Vishnu. See that.
Is it D? She doesn't have other like only attacks during the menstrual days.
So
she doesn't need preventive medication, I think.
That's what you feel. No. She got a disability. Her productivity is gone down. Less productive or absent from work on other migraine days also. And so she has got both during periods and also outside migraine, outside period time. So you have to choose not E, not D. Anyway, let's go back. So it is, you have to add a CGRP monoclonal antibody for prevention and change sumatriptan 100 milligrams to provatriptan, which is a serotonin 5-HT1 antagonist. So preventive therapies, there are indications. The recommended are if there are more than 4 migraines a month with no disability. If there is a disability like missing work and decreased productivity, 4 attacks are sufficient. And if severe disability is there, more than 3 or more are okay. But you can start less than this also. So what is the prevention goal? And then we have to tell them that we're not going to do any magic. You will not get a 20%, even 100% relief from whatever medications we are giving. Reduce migraine frequency by 50% or more, reduces severity, duration, and disability, and improve the quality of work. So that these are the Candesartan is available in Indian market, is very useful, and these are the level A established efficacy preventive medications: divalproex sodium and provatriptan, and menstruation related migraine, metoprolol, propranolol, timolol, topiramate, and level A established parental, eptinezumab, eranezumab, fremanezumab, and galcanezumab, and Botox. Level B, probably effective, are amitriptyline, atenolol, lisinopril, memantine, nadolol, and Botox. So if you look at whatever prescription practices you have, you will be prescribing most of the time level B. We're not going to level A. At times we go. So the consensus guidelines for when to initiate CGRP blocking agents, they can now be considered first-line treatment also. And this is a March 2024 guidelines which are released, and you can see a headache, March 2024. CGRP blocking agents can now be considered first-line treatment, no longer need to try 2 other agents with the level A or B evidence of efficacy. But problem is cost, comorbidity, and patient preferences. So atogepant prevention and rimagepant prevention as well as acute, ubrogepant only acute, and javegepant, which is a nasal surrender, that is only acute treatment. With the moderate to strong inhibitors or inducers, you have to be that CYP34A inhibitors, you have to be very careful. These are the new oral CGRP blockers for migraine. Second case, a 38-year-old woman with hypertension and hyperlipidemia has migraine without aura, occurring 4 times a month with migraine prevention. She's on fremanezumab for prevention and ubrogepant as needed. So which of the following is true in this? We should know the mechanism of action. The CGRP is a vasoconstrictor, so it is contraindicated due to her hypertension. CGRP is decreased during attacks in patients with facial pain, but increased in patients with migraine and cluster headaches. CGRP is only found in CNS So CGRP blockers are safe in pregnancy. CGRP monoclonal antibodies act on A delta fibers, not on unmyelinated C fibers. So anybody, any takers for this question? Anybody can answer this? What is the correct answer for this? This is about CGRP, and people have done, I think, seminars on CGRP, should be able to tell. Shall I proceed or somebody is answering? Anybody who has got knowledge of CGRPs? So, no, the D is the correct answer. CGRP monoclonal antibodies act on A delta fibers, not on unmyelinated C fibers. Look at that. CGRP is a vasodilator and is involved in nociceptive transmission. CGRP levels increase during migraine, cluster, or facial pain attacks. In all attacks, it's found centrally and peripherally and may impact placenta health. It's not approved for use in pregnancy. Only thing it's true is onabotulinum toxin in part blocks CGRP by acting on unmyelinated C fibers, but the CGRP monoclonal antibodies on A delta fibers, not on unmyelinated C fibers, which is blocked by onabotulinum toxin. So in clinical trials, the side effects are very low. Constipation, 1.6 to 3.4%. Nausea and local injection for CGRP blocking agents. Site reaction is about 5%. Fatigue, 3 to 6%. But in the real world phase 4 data, constipation is seen more often. That is up to 20%. Second most common side effect of erinumab and can be severe also. Nausea is 1 to 3%. Local injection site reaction, 1 to 3%. Hair loss, muscle cramps, hypertension. The post-marketing data suggests erinumab may be associated with hypertension. So some care, some caution has to be there for CGRP blocking agents. Let's look at a case 3. 35-year-old man with no known comorbidities presents with new onset severe headaches. The attacks are sudden in onset, searing. The pain is behind and around the right eye and into the temple. He notices that his right eye is sensitive to light, gets teary, and his right lid droops. The episodes last about 10 minutes, and during it, he paces and hits the right side of his face. He had 6 attacks a day over the last 2 weeks. Neuroimaging and labs were normal. What is the best treatment option for this? Verapamil, 40 milligrams 3 times. Verapamil, 40 milligrams 3 times with steroid course, indomethacin, gabapentin, and carbamazepine. Anybody? You should know the indication here because we keep getting so many headache cases. We should be able to differentiate this type of headache into a particular category. Anybody can answer? Are you all there?
Carbamazepine.
Carbamazepine. Okay.
So this is Sancta.
Indomethacin.
Indomethacin. That's correct. Indomethacin. So the indomethacin, 25 milligrams thrice a day. So cluster headache, paroxysmal hemicrania, SUNT, and SUNA. These are the TSACs, and which I will again and again talk today. The cluster headache is 15 to 180 minutes, severe, very severe, autonomic symptoms. And we'll see the characteristics and the diagnostic criteria in coming slides. And orbital pain every other day to 8 times a day. There will be restlessness and agitation. So you can, steroid injections also can be given, valproic acid, verapamil, triptans, inhaled oxygen are the best treatments. Paroxysmal hemicrania is 2 to 30 minutes, severe, very severe, autonomic symptoms, and orbital pain more than 5 a day, and indomethacin is the drug of choice. The hemicrania continue also can be persistent for 24/7 for more than 3 months, moderate, severe, Autonomic symptoms may be there, and you can have restlessness, agitation, or worsened by movement, indomethacin. So now you should identify what are the indomethacin sensitive headaches. And sunk 1 to 600 seconds, STAPS, moderate severe autonomic symptoms, orbital or supraorbital, and lamotrigine, the drug of choice. So with this, we'll again come back to this. Let's fourth, 32-year-old lady has been suffering from cluster headache since the last 12 years. She has developed menstrual irregularities also over the last few years. The MRI brain and MRA are normal. Prednisolone and verapamil were used for prevention and sumatriptan for acute attack, but she has been using brufen in excess and developed gastric irritation. So that means both these drugs are not available, not working properly. So which is the evidence-based recommendation for cluster headache out of all these 5? What is the evidence-based recommendation for cluster headache? Guess you should be able to tell.
Oxygen, inhaled oxygen.
Inhaled oxygen by none. That's very good. So inhaled oxygen by nasal catheter and recommendation for acute cluster headaches and treatment sumatriptan, zolmitriptan, 100% oxygen. These are all level A things. Sumatriptan 20 milligrams nasal insufflation, level B, zolmitriptan, and sphenopalatine ganglion stimulation, and dihydroergotamine. They are not insufficient evidence for prednisolone and ergotamine. So because if we are not able to give 100% oxygen, you can give zolmitriptan or sumatriptan. So AHS guidelines for prevention of cluster headache include suboccipital steroid injection, which is level A, and that's for episodic as well as chronic cluster headache. Lithium, level C. Verapamil, level C. Warfarin, refractory chronic, that is level C. I don't know how this acts, but it's mentioned in the literature. Melatonin, pravotriptan, sodium valproate, probably ineffective. And candesartan, probably ineffective. So these are the cluster headache guidelines. Based on the best evidence and tried and failed approaches, the next steps include occipital nerve block with steroid injection. Consider high dose of verapamil, but monitor with EKG. Level C evidence, but considered first-line treatment by American Headache Society. Well, lithium is considered more for chronic headache, cluster headache. The side effect profile is so much, it's not to be considered, in my opinion. Galcanezumab is FDA approved for episodic cluster, 300 milligrams monthly. The referral for sleep study, 50% of patients with cluster headache have sleep apnea. Offer sumatriptan nasal spray or injection, faster onset than tablets, hence quicker relief and better efficacy. The characteristic of cluster headache has got a timing with circadian rhythm that you will see in coming slides. Case 5, a 25-year-old man with no significant medical history slipped and fell 4 weeks prior while running. He landed on his back, hitting his head on pavement. 20 minutes post-traumatic amnesia was there. In emergency, he reported headaches, dizziness, and nausea. The CT scan head is normal. Then this happened 4 weeks prior. So he presented now with persistent, moderate, throbbing, holocephalic headache with intermittent nausea and light sensitivity, feels off balance, and reports of brain fog. The pain responded to ibuprofen. In this context, which of the following is true? At this point, continuing over-the-counter analgesics is appropriate for this patient. This patient can be treated that he will likely be better in 3 months. The patient is at low risk for developing central sensitization. This patient meets criteria for moderate to severe traumatic brain injury since he continues to have symptoms. Offering amitriptyline is the next appropriate step. So identify the type of headache and then answer. We keep getting these type of cases that मेरे को सिर में चोट लगा, then I have started having headache. Can you identify this? Any answer? Forthcoming for very important. Anybody? So this is what headache is this? Identify the type of headache. It is in the context of injury. So it's a traumatic brain injury. So is it post-traumatic headache? The drug is amitriptyline. Traumatic brain injury, whiplash injury. Onset is within 7 days of injury or of regaining consciousness with the ability to report pain. So if it is an acute onset, remission seen within 3 months of onset. If it's chronic, it persists beyond 3 months. ICH3 appendix suggests there may be a delayed onset between 7 days to 3 months. The phenotype of this headache is not defined. If pre-existing primary headache worsens because of the injury, both the primary disorder and the diagnosis of headache attributed to trauma or head injury are used. May be called post-concussion syndrome if it has several of the following symptoms like fatigue, reduced concentration, psychomotor slowing, mild memory problems. So you can differentiate. There are two important aspects here: mild traumatic brain injury and moderate to severe traumatic brain injury. That's why history taking is very important. Loss of consciousness for more than 30 minutes, GCS less than 13, post-traumatic amnesia for lasting more than 24 hours, alteration level of awareness for more than 24 hours, imaging evidence of traumatic head injury. All these present or absent will make it mild or moderate to severe. If they're absent, none of the following, then it is mild. Why we should identify mild is associated with one of the more signs and symptoms: transient confusion, disorientation, impaired consciousness. So mild TBI, if you identify, has got more chances of developing post-traumatic PTH. This is a known entity. PTH appears to be more common after mild traumatic brain injury than after moderate to severe traumatic brain injury. Isn't it surprising that it is more common after mild? Persistence of PTH after mild TBI is common. And about up to 60% experience headache at least for 3 to 12 months. Treat according to the phenotype. Migraine phenotype is more common than tension type headache, so treat accordingly. Consider to treat common associated symptoms like sleep disturbances, anxiety, and depression. Evaluate and treat for medication overuse headache. And then headaches that are occurring on 15 or more days per month as a result of regular overuse of acute or symptomatic headache medications for more than 3 months. So this is medication overuse headache seen in 1 to 2% of general population, and headache 15 or more days per month developing as a consequence of overusing acute headache medications on 10, 15 or more days per month for more than 3 months. A RCT was needed. The 68 studies have been reviewed. Treatment of medication overuse headache, early discontinuation and preventive medication both, and mostly botulinum toxin helps. The paradigm is use non-steroidal anti-inflammatory drugs or ASA early on, but avoid medication overuse for the PTH I am talking. If insufficient response, then can be used combined analgesics like caffeine plus aspirin or topiramate or triptan, migraine phenotype. More than 8 headache days a month with impairment despite acute treatment, consider prevention. Preventive medications are listed already. And you consider associated symptoms are present, insomnia, anxiety, or depression, then choose a correct drug. And if you have got a TTH, that's a tension type headache, then you select amitriptyline and mirtazapine or venlafaxine. Migraphenotype, you would select beta blockers, candesartan, amitriptyline, and CGRP monoclonal antibodies and Botox. Case 6. 52-year-old lady presents with severe episodes of facial pain. The pain is over right cheek and radiates to right temple. Starts abruptly and feels like an electric jolt. Lasts about a minute. On VAS scale, it is more than 10. That means 12. The pain is triggered by touching her cheek or even a wind on her face. She is having several episodes a day, and in between there is a dull, mild to moderate continuous pain. There are no autonomic or migraine symptoms. Dental examination is normal. MRI brain is normal. Which of the following is true in this condition? First line treatment is gabapentin, 300 milligrams TID. MRA of the brain must be performed to make the diagnosis. Microvascular decompression is the first line for surgical intervention in refractory patients. Unilateral presentation is more consistent with multiple sclerosis. The pathophysiology of demyelination only applies to classical trigeminal neuralgia. So, obvious it is a trigeminal neuralgia case. Everybody is able to identify that. But identify the correct answer. And what could be the correct answer in this case?
C.
C, that is?
Microvascular decompression for surgical intervention in refractory patients.
That's correct. That's correct. So then if you look at trigeminal neuralgia, it can be idiopathic and classical trigeminal neuralgia, secondary trigeminal neuralgia, and recurrent paroxysms of facial pain in one or more divisions of the trigeminal nerve with no radiation beyond, lasts a fraction of a second to 2 minutes, severe intensity, electric shock like. So the evidence-based medicine for this is level A is carbamazepine, that is a sodium channel blocker, and 100 milligrams BID starting dose. That is level A. And Lestol or level B or level C, the desoxycarbazepine. So the drug of choice is that gabapentin is C. We tend to use pregabalin and gabapentin more often. So now we'll concentrate a bit on trigeminal autonomic cephalias, which are listed here: cluster headache, paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing, that is SUNCT. Short-lasting unilateral neuralgiform headache attacks with cranial autonomic symptoms, hemicrania continua. So these are 5 tags which you should always learn and try to differentiate in your OPD. The diagnostic criteria, as I said earlier, are for cluster headache, at least 5 attacks, fulfilling all the criteria listed in B and D. See, severe or very severe unilateral orbital, supraorbital, or temporal pain that lasts for 15 to 180 minutes, that is 3 hours, when untreated. Either or both of the following, at least one of the following symptoms or signs ipsilateral to the headache, that means same side: conjunctival injection under lacrimation, nasal congestion under rhinorrhea, eyelid edema, forehead and facial sweating, forehead and facial flushing, sensation of fullness in the ear, meiosis under ptosis. Second, a sense of restlessness or agitation. These symptoms I'm not going to read again, but they keep on coming again and again for all the attacks. Attacks have a frequency between 1 every other day and 8 per day for more than half of the time when the disorder is active. It's not better accounted for by any other ICHD3 diagnosis. Then now let's look at the paroxysmal hemicrania. The attacks here, they are severe unilateral orbital, supraorbital, or temporal pain that lasts about 2 to 30 minutes. The headache is accompanied by more than one of the following, that is conjunctival injection or lacrimation, nasal congestion, rhinorrhea, eyelid edema, forehead and facial sweating, meiosis or ptosis. The frequency of these attacks are more than 5 per day. For more than half of the time, although periods with lower frequency may occur, they are prevented competently by therapeutic dose of indomethacin, that is paroxysmal hemicrania. And short-lasting unilateral neuralgiform headache attacks, SUNHA. At least 20 attacks fulfilling criteria B to D. And of course, we are not going to read all the C, but this is very well known to you. Let us concentrate on the B. Moderate or severe unilateral head pain with orbital, supraorbital, temporal, and other trigeminal distribution lasts for 1 to 600 seconds and occurring as single stabs, series of stabs, or in a sawtooth pattern. I'll show you a diagram of all these pains, how they occur. Attacks have a frequency of at least one a day for more than half of the time when the disorder is active, not better accounted by another ICD-3 diagnosis. Let's look at these SUNCT and SUNA. The SUNCT is attacks fulfilling criteria for 3.3 short-lasting unilateral neuralgiform headache attacks, which we just read, and both of conjunctival injection and lacrimation or tearing should be present. The SUNA, only one or neither of the conjunctival injection and lacrimation can be there. That means SUNA has got no autonomic symptoms that much of features. Hemicrania continua, that's the last one. All of the following characteristics: unilateral pain without side shift, daily and continuous, without pain-free periods, moderate intensity with exacerbations of severe pain. At least one of the following autonomic features occurs during exacerbation: ipsilateral to the pain, conjunctival injection under lacrimation, nasal congestion under rhinorrhea, ptosis or meiosis, complete response to therapeutic dose of indomethacin. So if you look at the autonomic cephalgias, and this is a very interesting diagram, shortest duration of attacks is by SUNCT and SUNA, followed by paroxysmal hemicrania, then the cluster headache, then hemicrania continue longest duration of acute attacks. But this is the lowest attack frequency. Here it is highest attack frequency, that is SUNCT and SUNA. And if you have duration, if you want to look at 1 second to 10 minutes is the short lasting things. 2 to 30 minutes the paroxysmal hemicrania. Cluster is 15 minutes to 3 hours. And hemicrania continue more than 3 months, the constant. Rest have a frequency of 100 per day in the SUNCT and SUNA, more than 5 paroxysmal hemicrania, cluster 1 to 8 per day. And then I'll tell you the treatments, what are the treatments that are given. Indomethacin, ineffective for SUNCT and SUNA, effective for paroxysmal hemicrania, cluster ineffective, but hemicrania continua effective. You can see the clusters, how they are coming, 15 to 180 minutes, 1 to 8 attacks, the side-locked headache, cranial autonomic symptoms. They are side-locked. You can see in the diagram. The diagram shows it side-locked in all the sides. The frequency and duration mentioned. We have already seen that, and you can see the frequency very, very high in SUNCT. And the hemicrania, 20 to 30 minutes, 5 to 40 attacks per day. Continuous pain with hemicrania continua. So the cluster, paroxysmal, SUNCT, hemicrania continua, migraine, trigeminal neuralgia, primary stabbing headaches. The pain localization somewhat the side locked, unilateral, except migraine. See, primary stabbing is variable, but most of them are side locked. And the duration is seconds to minutes to hours. And so responsiveness maybe to indomethacin we should be judging. So the diagnostic criteria, again, we have mentioned already, there are cluster headache, officials are not going to details of that. And we'll go quickly into second questionnaire. The common features: quick onset, offset, 5 to 15 minutes. And typical migraine features may be there for the cluster. And triggers only work when the cycle called clock-like predictability of attacks. So you can see 2 a.m. attacks. Whether they are in any part of our world, this happens at 2 a.m. 2 a.m. in Denmark, you can see Sweden and Taiwan, Germany, where it's got a circadian rhythm attachment to the cluster headache. So the treatments we have already mentioned, and what the new thing that has been brought in is non-invasive vagus nerve stimulation, ipsilateral greater occipital nerve block, and oral steroids and ergotamine. So this block is level A, and I'm going to show you how to do the blocks, and which will be very interesting, and anybody can do that. And you can see triptans are also very effective on level A evidence. And what are this is what I just showed you. Again, it is a slide got repeated. And preventive therapy, verapamil level C, and European field that is level A. And galcanezumab, 300 milligrams monthly injections. This is, I think, very effective, has been proven. But it's only for episodic cluster headache, but not for the chronic cluster headache, which it is ineffective. The paroxysmal hemicrania and hemicrania continua, we have already celecoxib and verapamil, melatonin, sphenopalatine ganglion block, occipital nerve blocks, which we are going to see in coming slides. The SUNT and SUNA together are called SUNHA, and diagnostic criteria we have already seen. And the first line treatment for these is lamotrigine. The others can be carbamazepine, topiramate, but start with lamotrigine. These are pain patterns which you have seen already. I'm not going to do that. Let's do the case now. 20-year male, 4-month history of 5 to 6 attacks per day of excruciating left-sided headache attacks lasting for 20 to 30 minutes. Always 1 to 2 hours after falling asleep and shortly after waking up, random times during the day. Left eye tears and droops, nose runs on the left side. Also notes neck pain and more on the left. The last 2 months, he notes he has a constant, much milder, dull pain in the left side of his head, mainly behind his eye. What is this TCA? Now, how do you treat this? This is the question. How do you treat? What is this trigeminal autonomic cephalgia? The attacks you are seeing. Somebody can answer. People are disappearing, but answer questions. Anybody can answer this?
Is it cluster headache because it's happening after 2 hours of sleep?
Okay. 5 to 6 attacks per day, excruciating pain. The cluster headache is the correct answer, and these are the following features: conjunctival injection and lacrimation, nasal congestion and rhinorrhea, meiosis and ptosis, a frequency of 1 every other day and 8 per day for more than half of the time when the disorder is active. So, and duration is 15 to 180 minutes. The treatments we have already seen, so not going to do anything. And there are the acute treatment guidelines, the chronic treatment guidelines, which we're not going to do now. We can refer it later. And the 100% oxygen already mentioned. And transitional strategies, the intranasal route also can be used, and intramuscular dihydroergotamine injection can be used. This same chap, he returns 3 weeks later. Prednisolone and nerve block did nothing. There's no relief from oxygen, sumatriptan, verapamil. He also says his neck has been hurting more, and when he tries to massage and stretch it out, it sometimes triggers an attack. Sometimes feels like sand is in his left eye. He resorted to tackling excessive amounts of ibuprofen throughout the day because it seems to dampen the symptoms. What's the diagnosis? How will you treat this now? Because he has used all the possible things.
Medication overuse.
Pardon?
Medication overuse.
Okay, medication. Okay.
Indomethacin drugs.
Right. Attacks are prevented completely with therapeutic doses of indomethacin. Now, how will you give indomethacin? What are the doses? How will you give indomethacin?
25 milligrams.
Okay.
Will increase every 3 days.
And how much you can go up to? What is side effects of indomethacin? Gastric irritation. So all of the following are characteristics of hemicrania continua and complete response to this thing. Start 25 milligrams BID or TID and titrate rapidly to effect. No higher than 100 milligrams 3 times. At least 50 milligrams 3 times to ensure response. Watch for GI adverse effects. People may not be able to tolerate it. That's why you should always give after meals. Can augment or replace with melatonin also. And celecoxib and gabapentin, verapamil, topiramate, and Botox, and that is vagus nerve stimulation may be alternatives. The 8th question, 56-year-old male, 3-month history of 10 to 20 attacks per day of very severe stabbing left side headache for 1 to 2 minutes. Thinks they can be triggered by brushing hair. The eye tears, swells, turns red. What's the diagnosis? What's the treatment?
Sunt and
Sunt.
lamotrigine.
Sunt is correct answer, and it is fitting into all the diagnostic criteria that has been studied already. And what's the treatment?
Lamotrigine.
Lamotrigine. Very nice. Right. 35-year-old male, 3-month history of 10 to 20 attacks per day, very severe. So this we have, I think, feels like cotton has in his ear during attacks. And what is the diagnosis and the treatment here? Temporal pain lasting 1 to 2 minutes. But there are no autonomic symptoms here.
So now,
Yes, Suna is the correct answer of the treatment.
same. So lamotrigine.
Same. Suna, start 25 milligrams and lamotrigine and titrate slowly every other day, and start with one valproate. If it is valproate, you have to be very careful because lamotrigine and valproate, they have mutual, there is a drug interaction. Dose is 50 milligram daily to start if on carbamazepine or other enzyme inducer. Suna treatment is lamotrigine. So the cluster, the paroxysmal hemicrania and Suna, these are the durations, frequency, genders, treatment, and lamotrigine, topiramate, gabapentin, indomethacin can be used on all these things. Right, case 10. 62-year-old female, new onset headache began in spring of 2020 at a grocery store checkout. Bilateral temporal regions. She is 62. Intermittent that day, but became continuous within 24 hours. Describes pressure type sensation, mild, moderate intensity with some throbbing and phonophobia, but no osmophobia, photophobia, nausea, vomiting. Now feeling well, but had concerns that she may have COVID-19 just before headache onset, low-grade fevers for few days and fatigue, but no headaches, loss of taste, smell, shortness of breath, etc. were there. She was using ibuprofen and muscle relaxant without much relief. Normal neurological examination, including fundoscopy, brain MRI. Earlier MRI was normal, done for a TIA. What is the diagnosis and treatment? You should be able to tell this.
Tension type.
No. Anybody else? This is what you are going to learn today, this type of headache. Anybody can guess? Others? This is called new daily persistent headache, NDPH. There are some characteristics for this headache. Persistent headache, fulfilling the criteria which are given here. Distinct and clearly remembered onset. She said grocery stores. With pain becoming continuous, unremitting within 24 hours. It's present for more than 3 months. Not better accounted for by any other ICH3 diagnosis. Neuroimaging is normal, everything else is normal. Common characteristics of NDPH, clearly remembered, often can tell you the exact date and circumstances when the headache started, and it lacks any characteristic features, may have personal history of other distinct headaches, but usually not. Often family history of migraine is also not there. And medical history may be there, irritable bowel syndrome, fibromyalgia, restless leg syndromes, restless legs, essential tremor, anxiety, depression. And female to male ratio is somewhat lopsided here. Males are more often seen. So the temporal relationship with flu-like illnesses, Epstein-Barr virus studied on mostly. So Lyme, Salmonella, adenovirus, Toxoplasma, HSV, E. coli, vaccine, surgery, head trauma, stressful life event, foreign travel. These are all can be precipitating factors. Must rule out other causes of new onset headaches and vascular like intracranial hemorrhage, aneurysms, spontaneous intracranial hypotension, IIH, intranasal contact points, infections, toxic and metabolic. The longer the duration without change, the less likely discovery of secondary causes becomes very less. So this is a very interesting thing. Many people come NDPH, we always miss because What the mind doesn't know that we can't diagnose. NDPH is notably refractory to traditional therapy, including muscle relaxants, triptans, tricyclic depressants, SSRIs, and SNRIs, anti-epileptic drugs. Less responsive to intensive IV treatment than other headache types. In general, match treatment to phenotype and don't give up. Keep trying something because these are the resistant cases. We got 3 more cases. 53 years old lady, migraine attack frequently reduced on topiramate. She developed new onset occipital headaches that are recurrent, explosive, severe, throbbing that occur just prior to or at the moment of orgasm during sexual contact. Patient had a prior MRI brain that was negative for intracranial lesions, but has not had cerebral arterial imaging. Diagnosis is obvious, but what's the treatment? How do we, if you come across such cases, how will you advise? What is the treatment? Is it a primary headache? Yes, I've shown you in the classification. It's a primary headache associated with sexual activity, bilateral in 2/3 and unilateral in 1/3 of the cases. Diffuse or occipitally localized in 80% of the cases. The onset of headache with sexual activity, it is mandatory to exclude subarachnoid hemorrhage, intra-extracranial arterial dissections, and RCVS. Vasoconstriction in RCVS may not be observed in the early stages, so follow-up studies also may be needed. It is self-limiting in most cases. Indomethacin, triptans, and propranolol are often used to treat this case. A gentleman comes, he says, if I don't exercise, I don't get headaches. But if I exercise, if anything that involves jumping or running will give me a headache immediately or within half an hour. Volleyball gives more headaches than other exercises. They impact my quality of life in a major way because my job is pretty physical. I missed a total of probably 4 months of work over last year because of this. What is the diagnosis and what is the treatment? Is it a primary headache? We got only 2 more questions.
Exercise headaches.
Yeah, very nice. Then exercise headache. Primary exercise headache brought on by and occurring only during or after strenuous, typically sustained exercises. Headache frequently with pulsating character, lasts more than 48 hours. Occurs particularly in hot weather or at high altitudes. Symptomatic cases occur like cardiac cephalia, subarachnoid hemorrhage, arterial dissection, and RCVS. So we have to be careful. The mechanism is unknown, possibly due to various arterial distensions and secondary to physical exercise. It's associated with internal jugular venous valve incompetence. 70% is seen when compared to 20% of controls. And again, indomethacin 30 minutes before exercise or beta blocker is very useful in this case. 36-year-old male, bilateral and posterior headache for the past 3 months. Headache triggered immediately by coughing, but also straining during bowel movements and other Valsalva maneuvers. Sudden onset headache reaches its peak almost immediately and then subsides over 20 to 45 minutes. What is the diagnosis? Sudden onset headache reaches its peak almost immediately and then subsides over 20 to 40 minutes.
Valsalva maneuver head.
So it is no, it's improved, it's aggravated, triggered. So what is the headache? Any guesswork? See, this is a primary headache or a secondary headache. Anyway, since answers are not coming, this is called primary cough headache. If you see, headache, remember coughing, also straining during bowel movements. It's a primary cough headache brought on by and occurring only during or after strenuous, typically sustained exercise. Headache frequently with pulsating character, occurs particularly in hot weather. And so the cough headache also is same as exercise headache. This is one, primary headache. Primary cough headache is rare. It accounts for 1% or fewer of the all headache presentations. It lasts between 1 second to 2 hours, brought on by and occurring only in association with coughing, straining, or other valsalva maneuver. This is symptomatic in about 40% of cases. The symptom of cough headache is present, but one has to rule out, like any other primary access headache. We have to rule out Arnold-Chiari malformation, spontaneous internal hypotension, carotid vestibular disease, middle cranial fossa, posterior fossa tumors, midbrain cysts, basilar impressions. That's what I was telling, that we should rule out secondary causes. Since subtentorial tumors accounted for more than 50% of the internal space occupying lesions in children, important to evaluate in pediatric population, especially for cough headache. Treatment again is indomethacin, topiramate, esdazolamide, propranolol, high volume cerebrospinal fluid removal. So these secondary causes which we should rule out, and you can see any type of tumors, Arnold-Chiari malformations, and aneurysmal bleeds. Last case, 40-year-old woman, stable, 25 history of migraine with aura, attacks about twice a month. She presented to emergency room after sudden onset, very severe headache while doing strenuous yard work this morning, and didn't respond to non-steroidal anti-inflammatories and triptans. Past medical history of Crohn's disease, the history of phonophobia, photophobia, nausea, vomiting, lightheadedness, neck pain, stiffness. What's the diagnosis? Sudden onset, very severe headache. What is this called? You know,
Thunderclap.
thunderclap headache, correct. This is thunderclap headache, severe headache, sudden onset, peak intensity in less than 1 minute. Must rule out more acute neurological events, but is often due to primary migraine. There can be vascular causes, non-vascular causes for this: subretinal hemorrhage, aneurysms, cerebral hemorrhage, cervical artery dissection, cerebral venous thrombosis, hypertensive crisis, RCVS, pituitary apoplexy. Could non-vascular also, spontaneous internal hypertension or hypovolemia, colloid cyst of third ventricle, meningitis, sinusitis, primary cough, sexual and exertional headaches, primary thunderclap headache, idiopathic. So that finishes our questionnaire, and these are the causes which one has to be aware: cerebral hemorrhages, dissections, venous thrombosis, temporal arteritis, RCVS, pituitary apoplexy, and aneurysmal warning leak. And also tumors, third ventricles, pituitary and cerebellum, myocardial ischemia, meningitis, sinusitis, spontaneous internal hypotension. So whenever we have these differential diagnoses, one has to consider, keep them in mind whenever you are diagnosing primary cough headache and primary exercise headache. So I think now comes the procedures in headache, and these are the interesting segment. What are the procedures? Peripheral nerve blocks, greater occipital nerve block, lesser occipital nerve block, supraorbital nerve block, supratrochlear nerve block, auriculotemporal nerve block. So how many are there? 5 nerve blocks. Every 2 weeks as needed, scheduled basis as a prevention. Indications: acute migraine or status migrainous, migraine, prolonged migraine aura, chronic daily headache, medication overuse headache, cluster headache, cervicogenic headache, occipital neuralgias, and contraindications are always skull defects or cranial surgery due to intracranial anesthetic. There may be diffusion problem. Sphenopalatine ganglion blocks, single or repeated twice weekly or longer intervals as needed. And acute and preventive treatment of migraine, cluster headache, and other attacks, trigeminal neuralgias, atypical facial pain, post-traumatic headache, local bone or sinus defects only, and trigger point injections. You can inject on a trigger point, single every 2 weeks as needed, in tension type, migraine, cervicogenic headache, myofascial pain. So these are the procedures. Peripheral nerve blocks, local anesthetics, plus and minus corticosteroids are injected near the nerves to block the pain strike signals. Target extracranial, sensory, trigeminal, and upper cervical projections. I'll show you the diagram. The central mechanism of action: analgesia lasts longer than local anesthetic effects. Improvement in allodynia and aura. The steroid injections in the upper cervical regions effective for cluster, indicating efficacy beyond anesthetic use. So these are the occipital nerve Here, superior nuchal line is and lesser occipital nerve. So this is superior nuchal line. This is a mastoid process. And each will select. The greater occipital nerve block, which is frequently given in the migraine. There are 12 RCTs which show reduction in headache frequency, intensity, and duration. There are 2 RCTs for cluster headache, indicates benefits from suboccipital corticosteroid injections. And the other headaches, 1 RCT supports use for cervicogenic headache. Only observational data showing benefit for other peripheral blocks. How do you use it for acute migraine or status migraines, prolonged migraine aura, interrupting cluster headache cycles, medication overuse, treatment of chronic daily headache, migraine management in pregnancy, occipital neuralgia and cervicalgia, the avoidance skull defects, which we said. So another set of choice is lidocaine, 1% to 2%, and or bupivacaine, 0.25 to 0.5. You can use a combo. Volume ratio is 1:1 to 1:3. And pregnancy lidocaine is preferred than ropivacaine. For ganglion block and cluster headache, you use steroids. For migraine, the evidence is lacking. So volumes, largest volume is 2 to 4 ml for this greater occipital nerve block. And anterotemporal nerve block, moderate volumes, 0.5 to 1 ml. And superior orbital and trochlear nerves, smallest volumes, 0.2 to 0.5 ml. And you can see the nerves. Let us look at the supraorbital and supratrochlear nerve anatomy. These arise from the frontal nerve, part of the ophthalmic division of the trigeminal nerve, travel to the superior orbital fissure and divides into the supraorbital and supratrochlear nerves. The supraorbital nerve innervates the lateral forehead, upper eyelid, and anterior scalp. The supratrochlear nerve innervates the medial forehead, nasal bridge, and medial upper eyelid. You can see these nerves which are seen here, which you are going to inject. Supraorbital nerve block, how will you do? Procedure overview, patient position, supine sitting, needle 30 gauge, 0.5 to 1 inch, volume is 0.2 to 0.5 ml. Insertion point, mid-pupillary line at the supraorbital notch. That is the supraorbital nerve which you are going to inject. Take your thumb and run it along the orbital ridge until you feel a notch. Go above that spot. Ensure the needle contacts the frontal bone, followed by negative aspiration. There may be orbital trauma, periorbital hematoma, extraocular muscle weakness, but that is a temporary. So the newer the take-home message from this talk is newer migraine-specific therapies that are available include 4 CGRP monoclonal antibodies for migraine prevention, erenumab and galcanezumab, pramanizumab, and these are all self-injectable, and eptinezumab IV infusion. 4 gepants are available: rimagepant, acute and preventive peroral; ubrogepant, acute peroral; atogepant, preventive peroral; and javegepant, acute nasal spray. 1 dietane, that is lasmiditan, and that is 1 5-HT, 1F agonist peroral. The real-world patient experience studies suggest similar efficacy and higher adverse event rates compared to those reported in clinical trials. Clinical trials are controlled situations, and phase 4 studies have shown constipation 10%. In trials, it is only 1%, like that. So there are many neurostimulators are available with proven efficacy, but you have to, the patient should tolerate the pain that is induced by these stimulators. The peripheral nerve blocks are very popular in headache specialists. So I think with this brief introduction, one should start injecting, and especially they may be, these individuals need not take medicines, oral tablets. Once in a while, you can inject once in 2 weeks. Other primary headaches are important to recognize. A range of secondary causes may need to be considered, and treatment options may differ. Attacks are easy to diagnose after ascertaining attack duration, pattern, and associated features. Thunderclap presentations vary in etiology, making it imperative to exclude secondary causes before diagnosing a primary problem. And in the end, neurologists play a vital role in primary headache disorders, given tremendous disability and diagnostic delays, which could lead to patient. Even after reading so much of neurology also, we always falter. We don't diagnose anything properly. We only know that they come, you write amitriptyline and Ciplar or propranolol and do load CBST, do an MRI and throw them out. That's not, we are not doing justice. Like we should start a headache clinic and address these various types and generate your own data and experience of various primary headaches. That's all from my side. Any questions or comments? Any questions or comments? Are you people interested in doing peripheral nerve blocks?
Yes, sir.
Like we should start, no? We should have our own data and we should expand. We should use our own mini lab, mini theater and start injecting. Okay. Okay, then if there are no more questions, I'll stop here and wish you all the best till we meet at another time with another interactive session.
Thank you, sir.
Thank you, sir.